Hello, my name is Frank Enseleit and I'm working at the University Heart Center in Zurich in the Department of Cardiology. My task today is to explain you how heart failure therapy works. We have certain types of drugs that can be used for the pharmacologic therapy of our patients. We have diuretics, ACE inhibitors, ARBs, beta blocker, mineral corticoid receptor antagonists, ARNIs, and IF channel blockers. I will tell you how these drugs can be used to treat our patients according to the 2016 ESC guidelines for the diagnosis and therapy of acute and chronic heart failure. First of all, it starts with diuretics for symptom relief and to reduce signs of congestion. Commonly used are loop diuretics, furosemide and torsemide, which have certain initial doses and usually daily doses that can be used in the patients to control the symptoms in heart failure. Beside loop diuretics, we have thiazides. This slide shows that the commonly used thiazide diuretics in heart failure with reduced ejection fraction. They have certain initial doses, but the treatment is more or less the same like with loop diuretics. The drugs should be titrated to the need of the patient. After we controlled symptoms and signs of congestion, we should add a therapy that reduces mortality in our patients. To do this, we have, for example, ACE inhibitors. This slide shows you a summary of all the ACE inhibitor trials done in the past. It shows you that you need 30 patients to treat to reduce one clinical event. So it's a very effective class of drugs. To initiate it, you should start with very low doses, then slowly titrate the patients up and aim at high target doses. These are the commonly used ACE inhibitors in patients with heart failure and reduced ejection fraction. In the center of the slide you see the starting doses, which are very low in these patients, and of course at the right hand side the much higher target doses. If the patients are not able to tolerate ACE inhibitors, we can use angiotensin receptor blockers in patients with heart failure and reduced ejection fraction. 3 of them are shown in this slide, with again lower starting doses and higher target doses. What else can we do for our patients? The next step is to introduce beta blocker therapy. This is an example of a beta blocker. This data from a beta blocker trial shows you that you have to treat 17 patients to reduce one clinical event. Which beta blocker can be used in patients with heart failure and reduced ejection fraction? We have 4 different drugs with again very low starting doses and higher target doses. What else can we do if the patient is still symptomatic and has a ejection fraction below 35%? Of course, we should add mineral corticoid receptor antagonist. What is the evidence to do so? This slide shows you the data from one trial done with spironolactone. The number needed to treat to prevent one event is 8. Again, a very effective class of drugs. These 2 drugs are usually used, eplerenone and spironolactone, with lower starting doses and higher target doses. However, we have overwhelming evidence from the consensus trial done in the last century to the more recent emphasis trial. And with all these drugs I've shown you before, we are able to reduce the death rate at 1 year from 15.6% to 6.09%. What else can we do if the patient has still symptoms and ejection fraction is below 35%? At the left-hand side of the slide is shown that we can replace the ACE inhibitor or ARB with an ARNI. An ARNI is an angiotensin receptor neprilysin inhibitor and can be used in heart failure with reduced ejection fraction. There's a lower starting dose and of course a higher target dose. What else can we do? In the center of the slide is shown that patients who are in sinus rhythm and have a QRS complex that is broader than 130 milliseconds, should be evaluated for a CRT. CRT stands for cardiac resynchronization therapy, and again, patients should have an QRS complex broader than 130 milliseconds and the left bundle branch block. What is another treatment option? If the patients are in sinus rhythm and the heart rate is over 70 beats per minute, we can try to treat the patients with an IF channel blocker. There's one drug on the market. The starting dose is 5 milligrams twice a day, and the target dose is 7.5 milligrams twice a day. If the patient is still symptomatic, we can consider digoxin, hydralazine, isosorbate dinitrate, or we can evaluate the patient for ventricular assist device therapy or even heart transplantation. Thank you very much for your attention.